So hi everybody, my name is Ki-Hung Lee. I'm a pediatric epileptologist. Basically I'm a neurologist with special training in treating epilepsy in children. Today I'm going to spend about an hour talking about very important points in diagnosing and managing epilepsy in children. So to start with, what are we talking about? Like any other disease, we need to really have a common definition among ourselves to communicate clearly. So when I talk about seizure, it means it's a sudden outward manifestation of excessive or abnormal electricity in the brain. And that could manifest as motor phenomenon, like jerking of arms and legs, or it could be change in their normal neurological functions, such as just lapsing into unresponsiveness or staring off, and so on. The seizures could be caused by many different diseases and different conditions, including epilepsy. So epilepsy is just one of the many different causes that could manifest as seizures. What is epilepsy? Epilepsy is the tendency toward recurrent seizures without very specific trigger. To make a diagnosis of epilepsy, you should have 2 documented seizures without any provocation. As I said previously, epilepsy could be caused by multiple causes. And just name a few: brain tumor, stroke, hemorrhage, and the brain malformation. Now, so why do we care? Because epilepsy is one of the most common neurological conditions in children. In the United States only, there's approximately 125,000 new epilepsy diagnoses. And when you look at 1,000 children, there is about 6 to 7 children affected by epilepsy. The epilepsy diagnosis is commonly starting on the age of 18 and after 50s. So there are 2 peak populations. One is children and the other is senior population. And the cost of treating epilepsy, it could be humongous. Just calculating the medical cost, direct medical cost, it costs up to $1 million. And that is not counting the social and economic costs associated with family members, taking care of the children, and the lost opportunity to contribute to productivity and so on. So it's very hard to estimate what is the real cost of really having epileptic children suffering from lifelong epilepsy. Now, I briefly touched on cause of epilepsy. The cause of epilepsy could be very variable depending on the age of onset. For example, when you see a seizure starting in infancy and childhood, it could be from birth injury, it could be a metabolic disorder, it could be congenital malformation. On the other hand, if a child was normal until certain childhood age and start having seizure at the age of 5, 6, you have to look at different causes such as genetic syndrome, CNS infection, brain tumor, and so on. Now, in adolescents and young adults, most common cause of new onset seizure or epilepsy is head trauma and drug intoxication, and certain lifestyle issue. For example, someone cramming for a final exam and getting sleep deprived, they could have seizure, but it doesn't mean necessarily they have epilepsy. I just mentioned that all the adult senior population could have new onset seizures, mainly because they have a different type of neurological disease such as stroke, brain tumor, and other metabolic disorders. Now, before we go into detail about how epilepsy affects children and how to make a diagnosis and treat, I'd like to just give you a very brief instruction how to manage acute seizure. We call it first aid for seizure. The first thing you do when you find a person seizing in front of you, the first thing you do is really turn the person aside with head towards the ground. The idea is that just to make sure that the child or the person seizing and vomit and aspirate. So that's really the ultimate cause of death when a child or epileptic person die during the seizure. So to prevent that, you really have to keep the person on the side, or at least the airway is not blocked by some vomitus or some food debris in the mouth. Then you have to consider whether the child needs to be transferred to a nearby hospital or not. And I emphasize this, most of the time, 97% of seizures happening in front of you will not really lead to any medical the 99% of seizures will not lead to any significant medical issue, meaning that most of the time seizures could be just observed in a safe position and safe place and don't have to take them to the emergency room. Now the conditions you have to consider emergency room visit is when a person is having multiple seizures in front of you or having prolonged seizures. So in other words, you started observing seizure a minute ago, and now it's 5 minutes later, still continuing. Then you have to consider that this person is going into status epilepticus or prolonged seizure. Let's say that the person with seizure is actually pregnant, you know that, and the person is injured, or the person has diabetes, then you have to consider taking them to the emergency room right away. Probably you may not know whether this is a nuanced seizure, but if you know the person and this person is having the first seizure, you have to take the person to the emergency room, mainly because this could be the beginning of serious neurological or medical disorders. The final thing is, do not put anything in the mouth or do not try to restrain the patient while the patient is seizing. Number one, it's not going to help stop the seizure. Number two, it could actually harm the person by doing that. So now you have a child that had a first seizure. What do you do? So the first question you have to ask yourself and your doctor is really whether the event you observed with your child is a seizure or not. And the second question is this the first seizure, is the first seizure really indicating beginning of a acute or chronic neurological or systemic disorder? For example, people with meningitis, encephalitis, stroke, bleeding, they all could really manifest as seizure as a first symptom. Some metabolic genetic disorder could present as a seizure as well. So if you just focus on the seizure itself, you may not really get the big picture. In other words, the big picture may be some treatable disease that you may be just ignoring. So it is very important to find out whether seizure is part of a bigger neurological or systemic disorder. Next is really to find whether there's any acute trigger. In normal people, in healthy normal children, just having low sugar or low sodium or low calcium could lead to a seizure. It doesn't mean that the child has epilepsy, but the fact that they had a low electrolyte or low blood sugar may have triggered the seizure. So it is very important to know that the condition just mentioned is ruled out, so that we don't have to put somebody on unnecessary seizure medication. The next question is, do I see a neurologist when I have a child with a nuanced seizure? The answer is yes. Whenever your child has a nuanced seizure, you have to see a neurologist. And I will emphasize this again and again, mainly because seizure is just a symptom. So you need to find out what is actually causing the seizure. So once you ruled out the acute neurological or significant medical disorder, then probably you don't have to see a neurologist every time. But it is very important, at least for the first seizure, you need to see a neurologist. Then final question is, do I need to start seizure medication or not? Again, this answer will be best answered by your neurologist. So we just mentioned about seizure precipitants. So what are the common cause of acute seizure without having epilepsy? So low blood glucose, this is commonly found in diabetic children. So you have a diabetic child who is on insulin or some medicine, and they're supposed to take the medicine and take food. Unfortunately, let's say child has a acute infection they cannot eat or they cannot digest, then their blood sugar drops precipitously, and that could lead to acute seizure. It doesn't mean that they have epilepsy or they need seizure medicine, all the evaluation. Just the fact that the child has diabetes and not eating properly, that could explain the whole seizure episode. Low sodium could happen with certain medical condition. Certainly you have to rule that out. Low calcium could also cause seizures. Low magnesium. Now, certain antidepressant or the stimulants for ADHD treatment could cause seizures. Now, this is sort of not common, but it is documented. When you're on some sleeping pills or sedative for long enough time and try to stop the medicine without tapering off, you could have a sedative withdrawal seizures. Severe sleep deprivation is known to be a cause of acute seizure, especially in young children or young adolescent who is really cramming for final exam and so on. So that should be considered. So we just mentioned the cause of different cause of acute seizure. So because we have to rule all of this out, we have to start with really detailed history and neurological exam. That's typically provided by a neurologist. And then you have to do some basic blood tests that include CBC, electrolytes, glucose, hepatic panel, and renal function. All of this testing is just try to rule out acute metabolic cause. And in some cases, neurologists may recommend a lumbar puncture to rule out CNS infections such as meningitis and encephalitis. And it is very, very important that neurologists make the decision in timely manners. So, for example, if your child started developing encephalitis and if you miss the window of diagnosis and treatment, it could lead to severe neurological outcome. Urine screen for drugs is important, especially in adolescents who may be having some drug withdrawal or acute drug intoxication. Finally, we recommend two tests. One is EEG, or we call it Electroencephalogram, and the other is neuroimaging studies such as CT or MRI. So what is EEG, or Electroencephalogram, and what does it mean when you have abnormal EEG? When you run EEG on epileptic patient, you will find certain findings we call spikes, sharp waves, or spike wave complexes. These are very, very characteristic findings associated with epilepsy. However, more than half of epilepsy patients show normal EEG, meaning that the first EEG at doctor's neurologist's office may turn out negative, but it doesn't mean that your child does not have epilepsy. So normal EEG or negative EEG does not rule out epilepsy completely. On the other hand, up to 4% of normal children has abnormal EEG, such as spikes and sharp waves. So actually, even though the EEG demonstrates some abnormality, it doesn't mean that you have to automatically start treatment or you have to consider your child epileptic. The next question is brain CT or MRI, and this is probably one of the common questions I am asked. CT could be done in acute setting, especially in the emergency room, to rule out gross abnormalities such as brain tumor, hemorrhage, and stroke. But most of epilepsy patients, especially I would say in children, do not have this condition. Rather, they have a very subtle abnormality or have normal MRI or normal brain. So CT is seldom helpful as a elective diagnostic tool. It could be a good screening tool at the acute emergency room visit setting, but never should be done in outpatient setting or neurologist's office. When I see children with chronic epilepsy, they have done several MRIs, really without any specific goals in mind. So in other words, you repeat MRI, even though the first MRI is negative, really doesn't give you any additional information unless the seizures are poorly controlled and surgery is considered. So my advice is, if you haven't done any MRI and your child has epilepsy, get an MRI. If the first MRI was negative, you don't have to repeat unless you consider a surgical option. Now, choosing anti-epileptic drug or anti-seizure drugs could be usually determined by a neurologist. And as a neurologist, I consider multiple factors such as seizure type, epilepsy syndrome, pharmacokinetic profile, drug interaction with other medication the child is taking and other medical conditions. And you also have to think about cost, because not all the parents or not all the families can afford to have a very expensive medication prescribed and refilled. So we have more than 12 different medications for different types of seizures, and this should be left to the neurologist seeing your child. But I want to make sure, I want to emphasize that the certain drugs work only for certain seizure type. So, for example, carbamazepine is a really very effective drug for partial epilepsy, but not necessarily for the generalized epilepsy. So how do we know what type of epilepsy your child has? That also should be really left to the neurologist. And typically, after the EEG, after the MRI, the neurologist will be able to determine what type of seizure or what type of epilepsy your child has. I emphasize monotherapy because when you're on multiple drugs, it's very difficult to know which drug is causing side effect or which drug is working or not. So again, it's very important to consult with your neurologist, but never consider adding more medicine, meaning better control. If you fail more than 2 drugs, you definitely have to consider seeing a specialist, because there is well-established data when you fail 2 anti-seizure medication and your child is seizing continuously. Actually, they need to have a very detailed evaluation, and you may have to consider non-medical or other alternative options, including brain surgery. I just mentioned drug interaction briefly. Some seizure drugs could inhibit the effectiveness of other drugs in various different ways. And that's one of the most important reasons why you should not keep adding more drugs to whatever the child was taking. Another question I hear often from parents is, why do we check the blood level of medicine? Well, probably the most important reason we check blood level of medicine is that when a child is not doing well. In other words, we prescribe medicine, a child is taking the medicine, and still the child is seizing. So we want to know why, and number one reason could be that child is taking medicine, but it is not enough. So in other words, it's not really hitting the therapeutic target. So by looking at the blood concentration, we could actually adjust the dosage of the medicine, and we can look at the drug interaction and so on, and that could be probably number one reason. Now, having said that, I do not recommend checking drug level in every single child, mainly because a drug level may not mean really much, especially when a child is doing well, has no side effect. So I recommend going by clinical observation rather than the number or the drug level. So you study medicine because your child has new onset seizures. So what do you expect? Now, 70% of children, when you start seizure medication, they respond, meaning that they stop seizing and they continue to develop well. On the other hand, 30% of children continue to seize. So what do you do when your child is on medicine or two and still seizing? So these are the considerations you have to give. Number one, is my child having some sort of progressive neurological disorder? There are many conditions that could be belonging to this category, and probably the most prominent one is brain tumor, or we have some certain conditions such as Rasmussen encephalitis, focal cortical dysplasia, and so on. So when you have the certain pathology, no matter what you do, the child is going to continue to seize. Then the second question is avoidable precipitant. Let's say the child has a very bad lifestyle. So in other words, like, child is, let's say, 13-year-old and has a very bad sleep hygiene. They don't go to sleep until 2 or 3 a.m. and they don't take medicine as well as they're supposed to, and so on. They need to really fix the lifestyle first. The third one is it's a real issue. So you're on this first drug and you failed, meaning that your child continue to seize, and then you replace the first drug with second drug and your child is still seizing. Then you have serious problem. So the real question here now is, well, is there any problem with drug absorption? So my child is taking medicine. Is the drug going into the system? Then the question is the dose enough? So then you have to really check the drug concentration and increase the dose. How about medicine? Maybe the medicine is not the right medicine for the specific seizure type my child is having. So maybe you should consider changing medication. Then finally, before you go into the next step, you really have to consider doing Video-EEG. The reason for that is, again, certain drugs work for certain seizure types. Now, a lot of times, if your child has one seizure every week or every other week, it's very difficult to capture or document seizure in the hospital. So in the typical setting, your neurologist will go by what you describe for your child's seizure. Unfortunately, just depending on the description of seizure, you may not get necessarily very accurate seizure characterization. So the medicine your neurologist is prescribing may not be the best medicine. So in that case, what you have to do is really put the child in inpatient setting, off the medicine, and document the seizure so that you can characterize the seizure better.